Welcome to our September webinar, our Quality Improvement Program update at the CPSO. If I could just remind everyone that signed in to mute their microphone during the meeting, that would be great. Just to start, I'll introduce myself and the speakers today, and then we'll go over the format of the webinar before we get into the content and the slides. My name's Ted Everson. I'm a medical advisor at the CPSO. I work within our quality programs and joined by a colleague, Dr. Mary Manno. Mary, do you want to just introduce yourself?
I'm Mary Manno. I'm a family physician by training. I also am a medical advisor here at the college, and I lead the quality improvement program section that is aimed at individuals and groups.
Thanks, Mary. Also from the college, we have our Director of Quality Programs, Mary Bayless, and our Manager of Quality Programs, April Jacobs, joining as well. They'll be signed in and working in the background. They're going to help support tracking and responding to any questions. So we're going to leave some time at the end of the webinar, hopefully the last 10 to 15 minutes for some discussion, questions, clarifications. So we'll try to save some of the questions until that time. If they're more straightforward, Mary may respond real time in the chat, but we'll leave some time at the end if you could hold your questions to then or put them into the chat. We do have a guest presentation today. Our guest speaker is Dr. Tara Kiran. She's from the DFCM at the University of Toronto. Dr. Kiran is the Fidani Chair in Improvement and Innovation, as well as Vice Chair of Quality and Innovation at the University of Toronto. Dr. Kiran's also a family physician with the St. Michael's Hospital Academic Family Health Team. Our format will be to go through a slide presentation initially. We'll cover the CPSO Quality Improvement Program updates initially, and then we'll have Dr. Kiran present on quality improvement offerings and resources that they have at the DFCM in Toronto. Just to note that we will be recording this webinar as with our past webinars. It'll be up on our website and saved there. So if you want to view it at a later date or reference it, it will be there as well. We have our previous webinars saved to our CPSO YouTube channel as well that you can view. So what we'll do is we'll get started. And again, we've launched a number of quality improvement options for physicians to participate in, and we want to cover the changes related to that, the current state, and how physicians can get involved with quality improvement and the resources and supports that we have available. So our objectives today are to review and explain the transition at the CPSO from our previous quality assurance or peer assessment program approach to the quality improvement basis of our current options. We'll review the tools that we have to support physicians in doing self-directed quality improvement, and we'll review and provide an overview of the current state of our CPSO QI program options for physicians to participate in. And then with our guest presentation, it'll review the QI offerings and resources that are available from the Department of Family and Community Medicine at the University of Toronto. I'll start with some background on the CPSO quality program and the changes that we've made. And I'll highlight a couple of important principles. One is quality of care. The other is something called right touch regulation. And so certainly some of the important work we do at the CPSO is that we definitely want to support physicians in providing high quality medical care. And with our quality programs, we've made changes. We've undergone a redesign, shifted to a QI-based program, and we want to go over that with you today. The other key principle with the redesign of our quality programs is something called right touch regulation. And I'll just spend a moment speaking about right touch regulation. So right touch regulation is a principle that we apply to all the work we do at the CPSO. It's based on a risk evaluation, and it provides a framework and guides us on determining the appropriate level of our involvement, whether that's in a particular matter, in a particular file, or in a particular area that we're active in. And this has been an important principle with the redesign of our quality programs. Some further background on quality at the CPSO. Physician quality requirements are outlined in the quality assurance regulation. So all members with an active license must participate and interact in one of our quality programs. Now, historically, this was through our peer and practice assessment program, and that had been in place for decades. And that program was designed around a 10-year interval. So a physician would be selected approximately once every 10 years. Starting in 2019, we started our redesign and transitioned to offering quality improvement based options for physicians to participate in. And we've launched a number of options that are available that we'll review today. Certainly, our peer assessment program still exists. It remains an important evaluation tool for our various committees. And an example would be that our age-related assessments for physicians over the age of 70 would undergo a peer assessment every 5 years. Further background, our peer assessment program had been doing approximately 3,000 peer assessments a year leading up to 2019, 2020. And some of our experience with that, and an important point, is that in approximately 90% of those assessments, there were no problems or issues that were identified. And so there's a couple of important takeaways with this. One is that physicians in Ontario are generally practicing at a really good level, at a very high level. And then that brings the question is the quality program and the resources we're allocating to the quality program offering value to physicians in Ontario if there's no practice change or impact with the quality assurance peer assessment program. So that was one of the reasons to look at a redesign and shift to a QI-based approach. So this slide further outlines that model. So with a quality assurance approach, which was our peer assessment program, there's an impact on a smaller number of individuals, and that's with the curve and the graph on the left side of the slide. Whereas with a quality improvement approach, there's the potential to have a bigger impact or shift on overall quality for everybody that's involved, everybody that's participating. And again, this is one of the principles that drove the redesign of the quality program options that we offer to physicians. So just to summarize the comparison and approach to quality evaluation with quality assurance, this has been done by our peer assessors. It's an audit of a physician's practice. We're evaluating care that's been provided in the past, and we're looking at physicians meeting a minimal acceptable standard. Whereas with a quality improvement approach, this is something that is intended to be more self-guided and self-directed. We do offer coaching and support as needed, and it's more forward-looking, so looking at care and impacting care that is yet to be provided. So a comparison between quality assurance and quality improvement. And I'll pass it over to Dr. Manno to go over the next few slides.
Thanks, Ted. So when it came to redesigning the program, we looked at an approach that would be needs-based versus a one-size-fits-all approach. And we hope to have more frequent engagement with the profession. So our goal is to engage with every physician every 5 years. And that could be through two potential streams. The first stream is QI for individuals, and a subset of that is QI for groups. That's basically aimed at physicians who are community-based practitioners primarily. Well, we recognize that many members have both community and hospital-based practices. The majority of physicians participating in QI for individuals at this point are community-based. As opposed to physicians who are enrolled in the QI partnership program, which we'll talk about in some detail. QI partnership is an opportunity for hospital-based physicians to participate in the program in a different way. Next slide, please. So we started out in 2019 with a pilot project that involved 260 family physician volunteers. And as you acquaint yourselves with the online tools and activities that we've developed, you'll be aware that many of those are centered around primary care practices, because that's where we started. And as we're going along, that we're shifting to accommodate other specialties as well. And we'll speak a bit more about that. In 2020, 1,700 family physicians were invited to participate. In 2021, an additional 6,000 were invited, and at that point, we began to include other specialties such as psychiatry, radiology, internal medicine, anesthesia, and surgery. In 2022, 4,000 members were invited into QI for individuals, and we also developed the group subset at that point. And this would enable us to include in the program a variety of practice settings and specialties with a bigger scope. Next slide, please. So the way the program is set up in QI for individuals, we're looking at a 5-year cycle, and we have a number of online quality improvement activities that individuals complete, including practice profile, self-guided chart review, and data-driven QI. And the idea is to, through completing these activities, one would have a sense of one's own strengths in terms of the practice or the work that you do, and also areas of potential improvement, which we all have. And I think as physicians, if we look back over the years, we've all been doing improvements in our practice, in our work over the years, but without that being acknowledged or set down in a formal way. So the way I see this program is an opportunity to actually get credit for what we already naturally do. We identify areas for improvement in our work, and we set about to test ideas that will change what we do and ultimately lead to an improvement in quality of care. So those ideas then get captured in a practice improvement plan, whereby we identify and set 2 SMART goals. And SMART is actually an acronym. We have some resources that help those who aren't familiar with SMART goal setting. SMART goals are specific, measurable, achievable, relevant, and timely. And once those goals have been set down in the practice improvement plan, then those are submitted to the CPSO, and one of our quality improvement coaches will review the PIP and provide feedback, written feedback in every case. Next slide, please. So a question that we're often asked is, where do improvement goals come from? Next slide. So I'd like to use an example that comes from the practice profile activity. This activity is an opportunity for us to look at things about our practice that are supporting our excellent performance as physicians, and also factors that may impede performance. For example, this is taken from a colleague's practice improvement plan. I'm a solo physician over the age of 60. Before completing this activity, I did not appreciate the impact on patient care and had no idea that I was at increased risk of a college complaint by virtue of being a solo physician over the age of 60. And this is not a question of ageism. These are just statistics that indicate that certain factors can be red flags or put us at risk of affecting our performance. And therefore, bringing those factors into our awareness can be very helpful. So this individual's goal for improvement was to mitigate risk and obtain collegial support for his practice of medicine. So in the current state, or at baseline, this doctor had little or no peer support. And the intervention that he had in mind was to rejoin a problem-based small group by contacting the Foundation for Medical Practice organization, for applying for affiliate privileges at his local hospital, and asking for an invitation to the local family physicians WhatsApp group. And the way that he intended to measure the outcome of his interventions, or the future state, or the desired state, was that in 3 months he would reevaluate his level of peer support. So this would be an example of an improvement goal that would arise from the practice profile activity. Next slide. Another activity that's built into this program.
Wow,
maybe those who aren't speaking could mute. Thank you. Is the self-guided chart review. And in this activity, we provide a checklist of items that will allow you to look at 5 records. We suggest that you choose patient records that reflect the type of practice that you do, and using the checklist to rate yourself on how well you're doing with record keeping, and also to ask the advice of a trusted peer. Have them look at your records and your checklist and get some feedback, which will lend an element of objectivity to this exercise. This physician, for example, when we went over the results of my self-guided chart review, my trusted peer noticed that I often neglect to include negative findings in the record. For example, in a 65-year-old smoker with abdominal pain, it would be important to document that the abdominal aorta was not palpable. So in this situation, the current state or baseline for this physician was 3 out of 5 charts did not include significant negative findings. The intervention that this physician chose was to set a reminder, which could be electronic or not, to document negative findings. And the outcome measure was to take a look and repeat the chart review after a period of 3 months to see if the performance had improved. Next slide, please. The third online activity is called data-driven quality improvement. And it's based on the idea that practice level data is available to all of us in some form. In some cases, if you're lucky, there's someone out there who's pushing data to you, which could be Cancer Care Ontario, or it could be Choosing Wisely Canada. In other cases, we have to look for our own data, maybe within our own EMR or observing our own practice. And so this is an example, some comments that come from physicians around data-driven quality improvement. The idea being that any goals that we devise that are based on data are statistically more likely to be achieved. So this person said, I had no idea that all that data was being pushed to me. Now I know that I can use my screening activity report, which is from Cancer Care Ontario, to create a goal. Or I can embed the I4C dashboard into my EMR. And there's also lots of help available to help us find data. Ontario MD, for example, is very interested in supporting physicians to use their EMR data, and there are other opportunities as well. Another physician commented that I can observe my own practice and think about the pebble in my shoe. So those things that trouble us as we progress through our day that sometimes we don't have the time to reflect on. For example, one individual said, I'm a therapist and I noticed that my counseling sessions run late 50% of the time. That sounds uncomfortable. Another colleague, as a specialist, patients have to wait 2 months to see me in consultation. Another problem potentially, although these days 2 months might sound good, who knows. Another physician, I'm a locum. How do I get feedback on my performance? There are ways. 25% of my patients prescribed opioids may benefit from deprescribing. And that's a pretty common situation, I think. Another colleague said, as a radiologist, I review about 10 interesting or challenging cases per week, but I receive little or no feedback on patient outcomes. All interesting ideas that could form the basis of an improvement goal. Next slide, please. Ultimately, the improvement ideas will be formatted in the practice improvement plan into a minimum of 2 and a maximum of 4 improvement goals. Excuse me just a moment. My apologies. I was saying that There can be a minimum of 2 and a maximum of 4 improvement goals contained in one's practice improvement plan. One of the 2 goals, and I should say, at a minimum, one of 2 goals can be related to physician health and self-care, because the college recognizes that this is such a huge area that most of us are struggling with during the last few difficult years. This physician, for example, looked at the CMA resources online and realized that she could structure a self-care goal for herself. She decided that she would leave her office for 30 minutes at lunchtime, at least 3 out of 5 days a week, to have some physical activity, perhaps go for a walk, do some stretching, or wow, eat lunch. That's something really unusual. Maybe even have a bio break. This physician decided that she would keep track on a calendar and give herself a check mark for each day that she succeeded in meeting her goal. And after a month, she would count her successes and reward herself accordingly. So these are some ideas about how physician health and self-care could form an improvement goal. And we've put in the chat the CMA resources around physician health and wellness, as well as those located at the OMA. There's a lot out there to guide us now. And in particular, in the OMA resources, there are some tools that actually can help us to assess our own level of engagement in our work and look at risks for burnout or even diagnose burnout and come up with some really meaningful approaches to manage that and to avoid further burnout. So I would encourage any of you to take a look at those resources, whether or not you decide to use that link to form an improvement goal. I think it may be helpful. Next slide, please. So we talked a little bit about the 3 online activities that each participant in the individual program will complete. I should point out that those activities are not submitted, the content of those activities is not submitted to the college. Those are for your personal reflection and your use in formulating areas for improvement. We do look to see that the 3 activities have been completed, but we don't actually review the content at this point in time. The once though you've taken the information from those activities and begun to formulate your goals and put them into your practice improvement plan, that's the piece that's submitted to the college, and that's the piece that one of us will be evaluating and giving you feedback on. In the majority of cases, the outcome of the review of the practice improvement plan leads to written feedback and a completion of the program. In about 15 or 20% of cases, the quality improvement coach who's reading the practice improvement plan sees an opportunity for enhancement. And in that case, those individuals are invited to coaching. Sometimes some goals just need a little bit of further development. And there could be identified issues during the PIP review, which could be around clinical care, practice management, or even wellness. And we have the opportunity to meet with members virtually. Video conferencing works best in order to review the practice improvement plan and work together to enhance it if needed. Next slide. So what's new in 2022 is that we've created a program or a subset of the individual's program, which allows a number of physicians to work together and devise a group PIP. For example, if I was working in a practice setting with 3 other physicians, we might choose to identify an issue with that we need to improve the way we're providing after hours care. And so we could come together as a group and develop a couple of goals for improvement within a group practice improvement plan that would address that need. So we started out in 2021 with 4 groups in our pilot, and we now have a large number. But the thing that I want to highlight here is that each individual member of the group completes the 3 online activities individually, and then the group members come together to devise a group PIP. And so the physicians are submitting one group PIP instead of individual PIPs. Next slide, please. And I think we're going to change over to QI partnership and go from there. Back to you, Ted.
Great, thanks, Mary. So I'm going to speak about another one of our QI program options called the partnership program. And what the partnership program is it's an option for hospital-based physicians to do QI as a group with their colleagues. So, the rationale and the goal is to, again, engage physicians in doing quality improvement. We know that it's a great way to improve or change clinical practice. And in the context of the partnership program, we're hoping that this is an opportunity for physicians to come together and support important things within their clinical environment, whether that's priorities within the strategic plan or various quality metrics that they want to focus on. The other aspect of the partnership program as a unique stream is that we recognize that physicians practicing in a hospital may already be engaged or are commonly engaged in different improvement activities. And therefore, this is an opportunity for them to have some additional recognition of that work that they're doing and use that as a way to meet their requirements with us and avoid duplication. The partnership program, therefore, is an option for physicians to participate in a hospital-based quality improvement project with their colleagues. And by doing that, they'll be able to meet their CPSO quality requirements for a 5-year period. Part of this program is that they still will need to do 2 of those reflective activities that Mary had spoken about that we provide access to once they're enrolled. And again, the context is that this should be something that's aligned with something that's important at your hospital and within your clinical environment. In terms of what you can decide to do, the design and the options are flexible. And I think a couple of key considerations are if there is something relevant that you've been looking at, maybe it's something within an updated strategic plan or department plan. Maybe there's an important quality theme or metric that you want to work on. This is an opportunity to engage your physicians on that initiative. So that'd be a consideration when deciding what to do. I think the other important design consideration is around the scope of the project, and that's based on what resources and expertise that you may have available to support the project. So recognizing that across the province, there are differing levels of expertise and resources and support available to implement a project, that's an important consideration when you're deciding what to do. At the end of the day, there's a lot of flexibility and we can support and help with deciding specifically what to do. In terms of the process, organizations do submit a proposal to us. We do have a standardized proposal form, and it follows a standard QI project charter format. So an organization drafts this onto our proposal form and submits that to our program to review. A couple of the key items are for a physician that is participating is really how are they engaged in the project in terms of reflecting on the project objectives, any data, and how they're participating with feedback. In terms of our experience to date with the partnership program, we did our launch in early 2021. We've now have 43 hospitals across the province that have had submissions and approved QI projects, predominantly organizational-wide type initiatives, but also some organizations are pursuing a strategy of department level or cross-department submissions. And we've had, large hospitals all the way to smaller community-based hospitals that have submitted and been approved. Just some examples, 3 hospitals on the slide here, Casey House, Collingwood, and Kingston. We're seeing these are examples of projects that have been approved, looking at reduction in unsigned physician orders, looking at safety around opioid prescribing, also looking at physician wellness, and then also looking at resource utilization and pursuing Choosing Wisely Canada hospital designation. So just a sample of what some organizations are doing. As mentioned, part of the partnership program is for a project that is approved and a physician that is enrolled. We then provide them access to 2 of the activities that they would be required to do that Dr. Manno had outlined earlier, practice profile and self-guided chart review. Once those are completed, like our other streams, physicians then would receive an exemption from any further requirements for a 5-year period. So for an organization that is interested in terms of next steps, this is the pathway. You draft and submit a QI proposal to us. We review it. Post approval, we then want to get a list of your agreed participating physicians. So we track their enrollment and update their status. And then we provide those physicians access to those 2 online activities that they would be required to do. Some of the key messages around the partnership stream as an option, for physicians, it's an option to meet their requirements with us. Physicians can concurrently claim CPD credits, whether that's with the Royal College or with the CFPC. And again, there's the opportunity here to reduce some of the redundancy, not only in the work that they're doing, but in some of the professional requirements that they have, again, for work that things that they may already be doing for their organization. For hospitals and for the leadership at a hospital, this is an opportunity to engage your physicians on doing quality improvement or participating on a project or initiative, something that's meaningful and relevant to you because of the additional benefits that they'll get with meeting our requirements, claiming CPD by their participation. I'll just mention briefly an option that we're piloting this year for our physicians that are over the age of 70, that if they've been included on a partnership project, we're trialing a pilot process where they meet with one of our physician QI coaches and potentially then avoid having an age-related peer assessment. We are looking at expanding and modifying this program as we look to 2023, and certainly more to come on that. So a summary of the current state of quality options for physicians to meet their quality requirements. We've talked about our QI for individual stream and as well the groups subset based on our online platform with the submission of a practice improvement plan. We've just talked about our quality improvement partnership stream, which is an option for groups of hospital-based physicians to do QI together. And as mentioned, our peer assessment program does still exist. So we're a physician not to participate in one of our QI program options, then they would be eligible to participate in one of our in a peer assessment program. Further information, if you have any questions or clarifications, here's the contact info from myself and Dr. Manno. Please feel free to reach out with any questions or clarifications for either of these streams.
Ted, could I interrupt just for a moment before we move on to our guest speaker? I think I neglected to mention that it is possible for any member to come forward and volunteer to participate either in individuals or the partnership stream. We are approaching year 4 of our first 5 years with the new program, and really all remaining members can expect to be invited within the next 12 months, really. So feel free to jump in if that's your preference. Thanks, Ted.
Yeah, so with that, let's move on to our guest presentation and speaker, and I'll pass it over to Dr. Kiran.
Thanks so much. I'm delighted to be here. I'm Tara Kiran. I'm a family doctor. And for the last decade, I've really been passionate about trying to improve the quality of care that I deliver, that our team delivers, and that we all deliver together. I started off really doing quality improvement work within our own practice, and now at the university trying to support others. I wanted to talk to you about 2 things today that I think are going to be helpful for you potentially to complete your CPSO QI requirements. The first is a new set of modules that we've released that I think can really help you when designing and completing your practice improvement plan. And the second is a new dashboard that we've developed for family doctors, by family doctors, that I think will be really helpful for the data-driven QI element, which of course links also to the other aspects of the program. In all of this, we're really trying to keep the physician's needs also at the center together with the patients. And so this is just about better care made easier, hopefully. Next slide. So to start, I'm going to tell you a little bit about our QI self-learning modules. Next slide. We have a longstanding history within our department of teaching QI, and it began with us teaching our family medicine residents. But over the last year, we've started to make our QI offerings available free online, and we have additional offerings now, one that's geared for faculty or teachers, and a new one that we're just have released that's on our website, and you can go to our website here, happy to put it in the chat, that is really directed towards primary care clinicians. So these are self-guided learning modules. They're modular. There's about, we'll talk about how many there are about 9. You can choose how you engage with them. And importantly, they're also free. So I definitely encourage you to check them out. Next slide. We cover a range of topics in the modules. There are 9 modules in total. They are self-directed, so you get to choose the pace, depth, and the order in which you want to do them. For example, you may just be specifically interested in thinking about how you can engage patients in your improvement work and may want to just focus on that module, or perhaps you're really focused on your practice improvement plan and really want to do using a QI methodology. In all of these modules, we have some key tools and concepts and resources that we share, and we've designed them so that they're good for beginners, but that even if you have more advanced QI knowledge, there are aspects where you can dig deeper, and there are also, for example, case studies where you can learn from others. Next slide. So they have lots of interactive elements. We encourage you to reflect. The deeper dives for people who want a little bit more. The stories from the field are those elements of case studies from others. We definitely include videos because there's different ways of learning, not just reading, of course. And so if you want something that's engaging in that perspective, we've got some videos. And what's really important is we actually integrate lots of practical tips into the modules too. Next slide. The heart of our module is module 5, I would say. And so module 5 is where you would learn about the model for improvement. And we also teach this pathway that we kind of go through, and you'll see that it does align very well to the improvement plan that you need to develop. And you'll see that those parts of the model for improvement, for those of you who are familiar, are kind of those little bubbles where they intersect with that pathway for improvement. We talk about PDSA cycles, how to do them, provide a lot of practical tips based on a decade and more of knowledge and experience from our family doctor faculty teachers. Next slide. So importantly, we have also, in addition to that core module, we have modules that we've learned can really enhance the content, because if you want to do QI well, it's not just about applying the PDSA cycle, but also, for example, engaging patients, taking an equity lens. Safety is a really critical aspect, of course, and so we have a module very specific to that, and then one on leadership. And then, of course, module 9, I should mention, is related to the CPSO QI program and how our modules can best support you completing that requirement. Next slide. If you guys are interested, please do check out this website, and I will put that into the chat after I'm done speaking. Next slide. So the second offering that I want to talk to you about is something called Care Canvas, which is a new offering from our department that we are going to launch in early November, and that I think will be a fantastic resource for family doctors who are interested in understanding quality of care based on data from their electronic medical record. And as I said, I think this one can really support your data-driven QI requirement. Next slide. So this new dashboard of ours, we've designed it, and I'd love to show it to you kind of at the end if we have time, to be an HTML product. It's interactive, easy to use, very user-friendly, and it leverages EMR data. And the data is all extracted from primary care practices and stored in a data safe haven. So this is a secure central database where the data is then cleaned and processed. And our team has been doing this for a number of years with the goal of producing research from primary care data. And we recognize the importance of now using that data to provide it back to physicians in a useful way that can support quality improvement. I'll tell you in a minute about the quality of care measures that the data will include, but it's certainly a range. And one of the great things about this dashboard is that it builds on years of research where we've really tried to figure out how to best identify, people with diabetes in an accurate way using the data from the EMR. Next slide. I think you skipped over it, but I did want to just acknowledge the many, okay, next slide. So this is, we'll go back one. So this was the Poplar team. So I wanted to explain what Poplar is. So Poplar is an initiative of 6 Department of Family Medicine, 6 family medicine departments at the various universities in Ontario, along with the Alliance for Healthy Communities. And it's this network of practice-based learning, network that's sort of behind the data that this dashboard uses. And any one of you who are family doctors can actually contribute to this network and receive this dashboard as long as your EMR is one of the 3 most common EMRs used in Ontario. Next slide. I did want to acknowledge this was a huge team effort to pull together, and specifically we had an amazing family doctor team who really helped us to design something that would be useful to family doctors. Next slide. So as I mentioned, we have a range of quality indicators that the dashboard is going to, that would provide back to physicians. So diabetes, high blood pressure, opioid prescribing, benzo prescribing, antibiotics, and a variety of immunization data as well. And we also stratify these indicators by age, neighborhood income quintile, and some other factors. Next slide. I should mention that I'm talking today mostly about the physician level dashboard, but actually we can provide this data at a site or clinic level, as well as at the Ontario Health Team data. But in all cases, it's private from a physician perspective. So that means no one other than you would see the physician dashboard. And even if we provide it at a site or OHT level, they can't see what the physician, they can't see the physician, any one individual physician's performance. It's all just at the aggregate level. Next slide. We took a lot of care in designing this dashboard, I will say, just in that we had a ton of user input from family doctors. We had them kind of help us in workshops. We also had them look at the dashboard and interview them kind of while they were going through it. So we do hope it's useful from that perspective. Next slide. And we are aiming for it to be ready in November. Next slide. We will be offering as well some continuing professional development once it's launched. The dashboard will be easy to sign into. You just need a OneID account. As I mentioned, the dashboard would be available at no cost. It's private and secure, so nobody would see your data but you. And it's important to note that the physician level dashboard actually does include patient level information. And I'll show you that if I get a chance to show you the dashboard where you can easily download patient information in a CSV file. For example, patients who are overdue for their immunization or who are overdue for a blood pressure check. You can download a list of those patients identified through your EMR ID so that you can easily follow up on them. Of course, it's also designed to help you with things like the CPSO QI requirement. Next slide. As I mentioned, anybody who is who has one of these 3 EMRs, TELUS, Acura, or Oscar, is able to sign up to contribute data to Poplar. So if you're not already contributing to one of the networks like Music or Utopian, these are located across Ontario, so it doesn't matter where you're located, but we could set you up with the right network and get you going so that our first iteration is to current users in November, but our next iteration will be in January. And if you're able to sign up, we'd love to have you contribute data and get a dashboard in the spring of 2023. Next slide. So this is just a little view of the dashboard. It's still not 100% ready, so some of this might change, but you can see we've got the measures at the left in that menu bar. We've tried to keep it a very clean look, so it's easy for physicians to kind of focus in on what's most important to them. You can see right at the top with diabetes, we've kind of highlighted things like the number of people whose blood pressure is over a certain value, the number of patients whose A1C is over a certain value, the number who are over 40 and don't have a statin. We felt like those are the three of the things that you might want to act on. And if you clicked on the download follow-up list, you would be presented actually with a list of options for downloading different CSV files, depending on who it is that you wanted to most follow up on. You can see on the right-hand side, there's tabs where you can look at how your practice has changed over time when it comes to things like glycemic control or diabetes follow-up. And then at the bottom, we have a really practical tip sheet where we have clinical resources and patient resources that we hope will be helpful to you. Next slide. So if you have any questions about any of this, just send me an email. Our website for our dashboard's not live yet, but it will be up on at carecanvas.ca in the coming weeks, and I'll post that QI courses link shortly. And if there's time, then I'd love to just give you a taste of what the modules look like live, because they are beautiful and really easy to use. Thanks.
That's great, Tara. Thank you so much for doing that, Tara. That's fantastic. Yeah, I mean, we could try to share, if you want to try sharing from your end, we could maybe give a couple minutes to just showing that. So how about I'll stop sharing on my end, and then we'll see if you can get up your content.
I'm just not seeing the page right now. Give me one sec. Okay, let me try again. And I don't know while I'm doing this if there are any questions that people had, but I'm happy to answer questions as this comes up. Okay, for some reason I'm only able to share my desktop, but I'm going to do that, and hopefully I have nothing embarrassing on my desktop right now. Can people see the modules?
Yeah.
Perfect. Okay, so I am going to just start the course here. And you can see here, these are kind of how you navigate the modules on the left. We've got the different modules and then the sub-modules. And let me just take you through one, for example. So when we start with module 2, patient engagement, you can see here we start everything with a little bit of a quote. We've got some one very focused article on the subject at most, the learning objectives, and then we start into the content, and you can see it's although it looks like there's a lot of content that's nice big font, and we try and break it up. We've got interspersed with the deeper dives for people who want it. It's what we call the stories from the field, as I mentioned. And in this case, for example, it's the why engage patients. And we have actually a very compelling video from one of our patient partners who talks about her own journey and why she chose to become someone who volunteers on a patient family advisory committee. We try and kind of make them as useful to people as possible in terms of, so we've got this improvement pathway, as I mentioned, and here we've got, some interactivity to try and figure out, so where is it that you can actually engage patients in your improvement journey and how? And so we've kind of put that here, and then we provide a real life example of a team that did that and where they managed to engage their patients. In this last chapter in the module, we have some specific considerations for how to engage patients and provide tips. So for example, here under accommodate, if you press the button, there's like a resource hub that we take you to support how to support engaging patients. Similarly, if you're thinking about how do we get a diverse group of people to support me, you can read about one kind of way in which you can try and achieve that. There's a great guide on compensation that we link to. So lots of good stuff here that we hope is practical for people. Just giving you a sense of, like, module 5 that I mentioned is the kind of cornerstone or key module here, and you can see we've got that improvement pathway, and we start with the improvement opportunity and kind of different ways in which you can identify that and kind of take through things one at a time. So and then maybe while I have that up there, I'm going to just show you a CARE canvas, because I think it's a lot more fun to see it up close. So this is what the HTML dashboard kind of looks like. You can get a sense of your practice, the proportion of visits that are virtual, for example, which is something that's increasingly important and interesting to us, I think, is how our practice is changing over time. Even the demographics of your current practice population in terms of age and gender, in terms of income. We have a little map to show you where your patients are living. And then, the proportion with select chronic conditions. Just a note that this is all dummy data, so some of it may not make sense. And then, as I mentioned, this is the diabetes page. You saw that, so let's look at the hypertension page. You can see here we've highlighted a couple of really important statistics, and we have this like red button where you can download the CSV file of the people who are needing follow-up. And if you scroll to the bottom, you'll see these. This is a placeholder right now, but we've got some great content to help guide you to some clinical resources. Actually, I think the diabetes one might have some real stuff, but looks like there's all placeholders right now. But yeah, we're really excited to launch this in November. As you can see, there's a few things we still have to work out, but our team's been working hard to get this done. So thank you. And I will stop sharing.
Okay, great. That's really great work, Tara. Thank you for sharing that. So we do have a few minutes left, and maybe we could use that to try to get to a couple questions. I don't know, Mary. I know Mary Bayless, our director, has been monitoring the chat. So I don't know, Mary, if you want to bring a couple questions forward to us that we could try to answer, or just if we should open it up.
I think we can open it up. We've had one question about why there are so many EMRs. It's not exactly about our program, but that's the one question that I see at this point. And Dr. Sarah Chang was asking about whether we share the deck, and both Mary and I have replied that this will be recorded and the recording will be on our website within the next couple of days. So people can reference, in fact, this recording and recording of all previous webinars. So I don't know, Ted or Mary or even Tara, if any of you have any background or insight into whether and why there are so many EMRs out there. And we're all smiling, I think, because we are guessing the reason. But if anyone wants to offer up an explanation, that would be great.
Well, since I have the most white hair, I'll give the historical perspective on this. And it's my understanding that the Ministry of Health has set the specifications for EMRs over time, and they make the decisions about which EMRs will be permitted. And so it's out of our hands, I think is the answer. I don't know if anyone wants to add anything to that. I do see some other questions in the chat, and I think there's one there from Dr. Hawkins, Ted, that relates to partnership.
Great. Yeah. So the question is, I work at a community hospital. My question is regarding the QI partnership option. Do we need to be selected for this, or can we apply directly? So what you do is, if you're interested or want to know what's happening at your organization, I would reach out to your medical leadership, whether that's your department chief or chief of staff or quality leadership, and inquire about what's happening. They could be developing something. We've presented and had discussions with essentially every organization in the province. So possibly there's something that they're working on. And if not, you could indicate your interest and start to work with them. So reach out to your medical leadership and see if you can get that, drive that discussion going forward. Let's see here. There's another question. As I'm over 70, do I now do both the QI and QA? And it looks like Mary just answered that. You don't need, you're not required to do both. Current state is, for the majority of physicians, it's the expectation to have an age-related peer assessment once every 5 years over the age of 70. As mentioned, we've been piloting a new process this year that would involve a QI option, and we're currently exploring and doing some development work on other options that we are hoping to communicate later this year. Okay. Any other questions? We're just down to the final minutes. And Tara or Mary, any final comments?
We have the pleasure of having two Marys, so I'll go first.
Mary, sure.
Tara, thank you very much for the presentation. It's heartwarming to me to see so many options available for data-driven quality improvement that's actually based on one's own practice. And so thank you for all the good work that you've been doing in that area. And I'm hoping that many of our members will take the opportunity to learn more about those tools and be able to do really meaningful and relevant QI using them.
And I just want to echo that as well, Tara. It was so good to see all the work that you and your team have been working on, and that the dashboards and everything that's coming in the fall is really incredible, and I think will be so helpful to all of our members. We have another question from Dr. Ismail regarding whether we have plans for specialties like lab medicine and DI. And I would say, yes, we do. We have had lab professionals participate in our QI program. We also have a partnership program from a hospital in the GTA that submitted a department-wide radiology partnership program. So it was a proposal that was submitted and approved. So we have had lab and DI professionals and specialties engaged in our QI program. And I think, as Mary and Ted said at the beginning of the webinar, once again, the goal for our QI program is every physician every 5 years. And so we're wrapping up, or just about wrapping up on year 3 of our 5-year cycle. So we have 2 more years. And if you haven't been invited or you haven't been engaged at this point, then don't be surprised if you get a notification from us. And as we said, this program has been quite iterative over the last 3 years, and we're always trying to tweak it. We're trying to follow a QI mindset in the development of this program. So we're constantly looking at information and data that we get and making some small, improvements to it. So yeah, so stay tuned for more information, and we're hoping to make some other small tweaks for it coming in 2023. I think there's one more question here, which is how much time is this QI process expected to take? And are the resources mentioned by Dr. Kiran for family physicians specifically? So it's a two-parter. Mary Manno, do you want to mention how long it takes typically? We do ask that question of our members and they do provide us. So this is based on what members tell us.
In the individual stream, the average length of time for going through the 3 activities, developing and producing the practice improvement plan seems to be around 12 hours. And that's associated for family physicians, for example, with up to 36 credits from CFPC and also a significant number of Section 3 credits from the Royal College. And Tara, did you want to speak to the second part of the question?
Anyone is welcome to use our QI modules. We have designed them with primary care clinicians in mind, so the examples are from primary care, but certainly many of the concepts are applicable to anyone in any setting, for example, related to patient engagement or health equity or the model for improvement, just that the examples are going to be primary care specific. The Care Canvas QI dashboard, of course, is though for family doctors and their practices.
And for any members who need help to apply some of those principles to their individual practices, it's always an option to reach out to one of us if you're stuck, because we're here to support you in the good work that you're already doing.
Great. Okay, well, thanks, Mary. Thanks, Tara, again. So thank you to everybody for attending today. Hopefully this was helpful. As mentioned, it's been recorded. It'll be up on our website. It'll be on our YouTube channel. Again, thanks again to Dr. Kiran for presenting. Great resources and tools that they've developed. So thanks again for coming. And I think that's everything. Have a great day, everyone.
Bye, everyone.